Good evening, everyone. We are so excited that you have joined us, and we're so grateful to our panelists this evening. My name is Edith Bracho-Sanchez. I am a pediatrician here in the Department of Pediatrics at Columbia University Children's Health. We have an evening packed with information for you. We want to get right to it. We're going to give people a few minutes to join. And while we do that, I want to tell you about a couple exciting things that are happening in our department. We have our 10th annual specialty updates for the general pediatrician coming up December 2nd and 3rd. It is a 2-day virtual CME course for pediatricians and peds and family medicine providers. You can register now. You can use the QR code that is up on the page right now. We will also be sending a recap of today's webinar, and you will find a link there for you to register. We also have, I can advance my slides, a little plug for our department's podcast. It is called The Stuff That Matters for Kids Health. You can find it really anywhere you listen to podcasts or on the QR code on the page. A lot of our wonderful pediatricians have been featured on it. And you can follow us on social media for expert advice and tips at Kids at Columbia. We are on just about every channel, so you can follow us at Kids at Columbia. So with that, let me introduce our wonderful panelists for this evening. Very quickly, the content that we will discuss this evening on our webinar is intended for general information only, should not be relied on as a substitute for any professional medical advice or treatment, and the views that we will be sharing this evening solely reflect the expertise and experience of me, your host, and our guest this evening. So with that, let me introduce our wonderful panelists. So first we have Dr. Melissa Stockwell. She is a professor of pediatrics and population and family health. She's also the division chief in the Division of Child and Adolescent Health. We have Dr. Lisa Saiman, who is a professor of pediatric infectious diseases and our hospital epidemiologist at New York Presbyterian Hospital. We have Dr. Ashley Stevens as well, who is an assistant professor of pediatrics and the medical director of the NYP Immunization Registry and EzVac. So let's get started. As a reminder, very briefly for this evening, you can type your questions anytime. We will try to get to them live, but we have also saved time at the end of today's presentation to answer hopefully as many questions as we can get to this evening. So we're going to start with RSV. We're probably going to spend the majority of our time talking about RSV, but we will, of course, also be talking about COVID at the end. And speaking of RSV, I want to start asking you, Lisa, Dr. Saiman, to take us back a little bit. I think historically, RSV, respiratory syncytial virus, is a virus that pediatricians and parents are familiar with. However, in recent years, there really appears to have been a shift in the seasonality of it and in the number of small children that are contracted it in any given season. And I wonder if you could just take us back and remind us of what RSV is, how it impacts children, and maybe tell us a little bit why we may have heard about it more in recent seasons.
Great question, of course. So as you mentioned, Edith, it's a very well-known virus. People know it as RSV, and it's a respiratory virus, and it is something that everybody gets infected with, usually within the first 1 or 2 years of life. And it was typically, before the COVID pandemic, it had what we call characteristic seasonality. It's a wintertime virus. So in the Northeast where we live, it would generally, cases would start in October and generally end around March. Then things really changed because of the pandemic. And during the pandemic, we all remember the lockdown periods, the time when we were protecting young children, a lot of mask use and social distancing. So as a result of that, there was a year or so when there was very little circulation of any respiratory viruses other than COVID. So those little babies that would ordinarily have gotten infected with RSV during their first year of life were protected, but now they were vulnerable in their second year of life because they had not been infected in their first year of life. And that's why we had what is also known as the triple epidemic in the past of RSV, influenza, and COVID. good news is that it really looks like this year we're going to go back to the way it was before COVID. And the reason I'm able to say that with some assurance is that there are wonderful surveillance systems in place in the United States run by the CDC and other organizations. And RSV usually starts in the South first, and then it comes up to us a month or so later. So yes, indeed, in the beginning of September, we got a memo from the CDC saying it's starting in the Southeast. You can expect it coming into the Northeast in a month or so. And sure enough, starting at the end of September, early October, we started to see our first cases. So I think that what you're describing, we definitely see it in kids that are older than the first year of life, but still the most vulnerable children are the tiniest babies. And we'll be talking about that more tonight, I'm sure.
Yeah, this is all music to my ears, Lisa, and I'm sure music to the ears of every parent as well as every pediatrician that is tuning in tonight, that this season may go back to what it used to be. And it really, for us, it was like every child who was going to get it that season, plus every child who didn't get it the past season, and we were just trying to catch up. And as you know, everyone listening, really, as Lisa mentioned, it's really the babies and their small airways and this respiratory virus that really gets them in trouble. So this season, we have something really exciting, in addition to potentially going back to what the seasonality used to be and has been known for years and years. And that is called, and it is a mouthful, nirsevimab. So I want to go right to you, Melissa, and ask you, what is this product that we have available this season for the first time ever? And how is it different than a regular vaccine?
Sure. Thank you. And I know that we sort of colloquially have been calling it a vaccine, but you're right, it actually isn't a vaccine. It's an antibody, or we could say isn't a way with a passive immunization. So if you kind of go back to our basics, when we give someone a vaccine, what we're trying to do is teach their body that the next time they see that infection, their body will create an immune response. And part of that immune response would be antibodies. And, for kids, usually we're giving a vaccine, they might need 1 or 2 doses, and then they would be able to sort of make this protection for, a lifetime. In this case, we're actually giving the antibody itself. So we're sort of taking it a step forward. And that's actually a little more similar to when we give a vaccine to pregnant women, say, for example, a vaccine to protect against pertussis, where we're giving it in their last trimester, or the RSV vaccine, which we'll talk about it in a little bit. And we're having in that case, the mother pregnant woman create the antibody, pass it through the placenta to the infant, and that antibody lasts around 6 months, so protects them for the 6 months of age. That's important because, as Lisa mentioned, it's really those very young kids in that first RSV season that we're really worried about. So what we're doing here is kind of mimicking that antibody, giving it to babies, ideally in their first week of life, to protect them through that first season. This antibody is a little bit longer lasting than other antibodies, and it will last through that first season, but then it won't work anymore. And we haven't necessarily taught the immune system to protect against RSV in the future, but that's okay, because RSV is really common. Every child will get it. And when that child gets it in the second season, except for a few children who have, are particularly at high risk, which we can talk about, the next time they get it, it will just be, a cold, and they don't need that special antibody protection.
Yeah, so it's a ready-made antibody to protect the most vulnerable kids amongst us, even if they're not making it themselves. It gets them through until they're big enough to make it themselves and make it safely, right? So,
right. Or get infected and not, again, their airways are bigger, as you mentioned. So if they get an infection, it'll just be, a cold, a cough, and not have them end up, getting very sick from it.
Right, not land in the hospital or have, God forbid, a worse outcome. Melissa, who was eligible to get this antibody?
Yeah. So the focus right now, so it's changed a little bit. So the original indicated population would be any child under 8 months of age. So once they hit 8 months, they're no longer eligible, but under 8 months. And ideally, again, giving it. So for those children who are born now during the RSV season, so for us here, if ever people are tuning in from the New York area and not from a different place in the country, it's October through March to get it in their first week of life, and then catch-up immunization for those up through 8 months. There are some children who would be eligible in their second season up to through 19 months of age, if they have certain things like chronic lung disease or severely immunocompromised and a couple of other things. This just kind of hot off the press from the CDC today, because there's a little less supply than was expected. That the focus right now is going to be on those kids less than 6 months age, so kind of holding off on that 7 to 8 month age, because again, those kids are a little bit older, their airways a little bit bigger. And then for those kids in the second season, who would also have been eligible for Synagis, if there's Synagis available and you can still order it, order it for those kids and maybe save their nirsevimab for the other children. But of course, if Synagis is going to be delayed, we don't want to delay getting protection for those most at-risk kids. We will talk a little bit about the maternal vaccine a little bit. If a mother got the maternal vaccine, then the infant does not need the antibody because you don't need the double. And if the mother got the maternal vaccine but too close to delivery, then you would need the antibody because the mom hasn't had a chance to make it. So there's a couple of edge cases, but in general, it'd be the kids under 8 months of age, and then in that second season for those super high risk kids.
Yeah, perfect. And I'll tell you, my nephew is 11 months old and he has RSV right now as we talk. I just got off the phone with him, coughing very badly, but handling it okay. And it really just shows you, right? Those kids under 8 months, and even more so the ones under 6 months, are really the ones that tend to get in trouble more than even in those last few months before they turn 1, right? And it really, for us as pediatricians and as parents, there really is a huge difference.
Listen, and the second thing is probably your nephew, this may be his second infection. He probably had RSV last year. So once you kind of had it once and you're sort of in that second group, so it's the bigger airways, but also it probably isn't going to be the first time that he's seen it. So that's why we're really, again, focusing on those younger kids.
Thank you for that. And a follow-up question, Melissa, is do we use corrected age or chronological age for babies who were born prematurely? And you can sort of tell us how we think about that a little bit.
Right. So it's a great question, but we use chronologic age, not corrected age. So and we actually do that really for basically all vaccines. Once you're sort of born, you're out into the world, and we may correct other things, like you're right, like your growth charts or other things that we do, but other screenings. But in this case, for vaccinations, we're really doing your chronological age. So it's from when you were born, not from when you might have been born.
Right. So if you were born 2 months ago, for all intents and purposes,
you are 2 months old.
RSV, in terms of getting the RSV immunization or antibody, you are 2 months old.
Yes.
Lisa, to go back to you, Lisa, for a second, in terms of the studies that were done before this product was approved, I wonder if you can take us back to what these studies showed in terms of the length of protection, how well it worked, so the efficacy, and some of the side effects that were observed.
Yeah, great question. So whenever we do these big studies, we compare the product, the nirsevimab, to a placebo. So that's the best kind of study to do. And they were very large studies, about 1,500 babies in each of the two groups. And what we are very interested in preventing is lower respiratory tract infection, that the child gets sick enough to have to go to see somebody, to go to a pediatrician, to have to go to urgent care, to go to the emergency room, and then, of course, maybe having to get admitted to the hospital, and then in the worst case scenario, having to go to an intensive care unit. So all of those different outcomes were looked at. And they, so the babies were vaccinated very early, as we've been talking about. to maximize their protection when they are at their highest risk, these very, very young infants. Because we know that otherwise healthy babies in that first 6 months, particularly in the first 3 months, really are at highest risk. So that's why we really want to get them this antibody early. And it reduced all of the things that we talked about. So it reduced the number of babies that had to go and have medically attended infections. It reduced and it reduced the hospitalizations, which is very, very important. And what we really want to think about is that really, in the big picture for all of the pediatricians out there that are listening tonight, imagine how different our offices and emergency departments would be if so many of those babies that got infected with RSV were not coming any longer. So this was a very successful outcome in terms of what we call vaccine efficacy. And in terms of the side effects, it was very well tolerated. Like all shots, because this is a shot, there were side effects at the side, injection-related side effects. And so I think that when we look at the risk-benefit, the side effects were quite minor and very easily described as mild to moderate, and the babies did quite well.
Yeah, which is so reassuring for us on the ground when we're recommending this product, right? And we can say to families, you know, it's really a little bit of soreness, a little bit of redness, as you would expect when your child is vaccinated. But other than that, I mean, it really, really prevented the scary stuff, right? The landing in the hospital, the having a really, really difficult and scary outcome, right? Very quickly, just to mention that you can continue to type your questions into the Q&A. We will get to them as best we can. There were some very interesting questions asked in the Q&A, and Lisa, thank you so much. You jumped right in and answered them. I'll very quickly share with the team because in the recording, they won't be able to see the Q&A. So someone asked, why does RSV come up from the south? One would think that cold weather and indoor activities would mean that it would be more prevalent here up north. And Lisa, I did not know this, but the epidemiology may have to do with an earlier start of the school year in the South. So thank you for that knowledge. I did not know that, but that might have to do with why the South may see it first and may help us predict what we're going to see here in the North. And then someone else asked, how many variants does RSV have? And we said you typed in that there's 2, RSV-A and RSV-B, and nirsevimab has activity against both. Thank you for that. Now to go to you, Ashley, we've talked about, you know, what it is and how well it works, and this product, this antibody becoming available really for the first time ever this season. Where can people get it?
Yeah, great question. So in the hospital, right after the baby is born is the best time to get this product, this antibody to protect your baby from getting RSV. Many of the hospitals are starting to get supplies now and can offer this product before you leave the hospital. And that's important too, because again, the youngest babies are most at risk. So you want them protected right off the bat. And because, again, this is an antibody, it's kind of not requiring your body to make antibodies. You're protected pretty soon after you get the injection. And it's a long-acting antibody that lasts at least 5 months. So once you get it, you don't need any more doses, which is really nice. And again, the best supply is probably going to be in the nursery or in the NICU if your baby needs to, you know, extra support initially before they go home from the hospital. Pediatricians are starting to get supplies, but unfortunately there are very short supplies. The manufacturer, Sanofi is the name of it, had underestimated the demand for this product because it's so good at preventing RSV. And a lot of parents of older children may have heard of RSV. Maybe, unfortunately, their older children were hospitalized because it's one of the most common reasons why kids get admitted to the hospital. And just thinking of the bigger context, every year there's at least 50,000 to maybe 80,000 hospitalizations for kids under 5 from RSV and about 100 to 300 deaths. And so it's a really serious disease, again, particularly in those youngest babies. So that's why right off the bat, it's important to get the product or get your baby protected. And then I know I'm going to jump the gun a little bit, but there is another way to protect your baby from RSV. Again, there's these severe shortages of nursivimab. So your pediatrician may not have it in stock. So there's a vaccine that actually can be given during pregnancy. And Abrivso is the brand name. Anyway, it can be given to pregnant women in their gestational age 32 to 36 weeks. And that will actually get transferred to the baby through the placenta. The mom will develop the antibodies, will protect the baby. The baby will slowly, get those antibodies transferred to them. So right when they're born, they're actually protected from RSV. So that's another way to protect the baby right from birth.
Yeah, no, and thank you for reminding us of that. There has been, unfortunately, a very serious shortage of the new antibody this season. Hopefully it'll be better next season, but there's a real tangible way to protect your baby, and that is through getting vaccinated in pregnancy. And Ashley, I wonder if you can tell us a little bit more about what those studies showed in terms of efficacy and the safety, because I know that there were some side effects that were a little bit concerning to women. I wonder if you can touch on that and what the data showed.
Yeah, so the data showed that it's very effective in preventing severe illness from RSV. And about, by 6 months, about 70% of hospitalizations were prevented in the babies that were in the trials. In terms of the side effects for the mom, usually pretty mild: redness, pain, swelling at the injection site, and, some additional support, report of feeling tired, feeling weak. Those, common side effects that can happen with any vaccine, compared to the ones who got placebo, which is where they got a fake injection of salt water in the arm. And so there were a few very rare but serious side effects. One of it being preterm birth, so meaning babies are delivered a little bit early, but that was actually only shown in the places, because this was studied in many countries. It was only shown in low-income countries, particularly in South Africa. And so it wasn't seen in, the studies done in the US, but it was something that was considered, and actually why they recommend giving the vaccine later in pregnancy. So between 32 and 36 weeks. And again, that gives the baby sufficient protection, but also is late enough in the pregnancy where, again, it was not something that was very common that there was preterm birth, but, something that they took very seriously, and they didn't want that to be, something related to the vaccine.
Yeah.
And then rarely, very, very rarely, and again, none of these were statistically significant, meaning none, and including preterm birth, it wasn't, clear that the vaccine caused these concerns, but rarely, some women, more in the vaccine group did have preeclampsia. And some babies were born a little bit underweight and had jaundice. But again, these were not, statistically significant, meaning not very strong evidence, and, may not have been caused by the vaccine. But those are just things to consider.
Yeah, whereas there was some very impressive efficacy in terms of keeping babies out of the hospital, and recommendation in terms of when you get it was moved to a little bit later, right? And related to that, Ashley, a question just came in to the Q&A. How long, what is the minimum interval between when a mom gets the vaccine and the baby is delivered to ensure that that protection has been passed down, and then the baby won't need the vaccine when they are the antibody when they are born?
Yeah, that's a great question. So we want at least 2 weeks to pass before mom delivers after getting the vaccine. And that, we think, gives the baby enough protection. And as a follow-up, there's not a need for a healthy baby to get both, the mom get vaccinated during pregnancy and nursivimab after birth. It's one or the other for healthy babies. There are going to be a few high-risk babies, particularly ones that are hospitalized in the NICU, that may have been born prematurely or had heart surgery and required bypass. Very rare situations where it would be beneficial to the baby for mom to get vaccinated and the baby to get nursivimab after birth. But in general, for a healthy baby, it's one thing or the other. And given the unfortunate supply shortages of nursivimab, there's no guarantee that there will be good supply of nursivimab in the next few months. So if a mom is healthy and is able to get it at her OB's office, the maternal vaccine is a good option to protect the baby from getting RSV.
Yeah, and there's a number of questions coming in about Synagis or palivizumab, and we'll get to those in just a second. But before we move on to talking about that, Ashley, I do want to ask you briefly about the RSV vaccine available to adults. Can you talk to us a little bit about that one?
Yes, so there's an RSV vaccine for adults, for older adults that are 60 or older. And the vaccine is approved. It's recommended that a patient talk with their doctor. So it's not recommended for every elderly person 60 and older, but particularly those that are high risk of getting very sick from RSV, because both young babies and elderly people are at risk of getting really sick from RSV. They can get pneumonia, difficulty breathing. And some people, especially elderly people, get admitted to the hospital, and some actually die of RSV. So it can be a serious illness, particularly in people with lung conditions or other chronic conditions. So it's important for those people to talk with their doctor. Not all offices, many offices actually don't have the vaccine. You actually have to get it from a pharmacy. Unfortunately, Medicare is paying for the vaccine given in a pharmacy, but again, there needs to be a conversation with the doctor. So there's a little bit of a process that needs to happen for a patient to be able to get this vaccine. But for many people, it's really beneficial and worth the effort that you need to go through.
Yeah. Such a different way of thinking of, vaccination, going to speak to your doctor first and getting vaccinated at a pharmacy. But something that might be of benefit to people out there who qualify. So Lisa, I want to transition back to you and ask you about palivizumab or Synagis and its role. Is there still a role for it? And if so, what is it right now?
Yeah, thank you. Great questions, of course. So we've had palivizumab for a while. It's also called Synagis, if people are not familiar with palivizumab. And it's been restricted to very high risk babies. So it's been restricted to babies that are born quite premature, or babies with cardiac conditions, heart conditions that we've been discussing. And it can be given in the first RSV season, and in the second RSV season for babies. It's been very helpful for that group of babies, but that's a minority of babies. It's only a small proportion of babies born that are eligible for Synagis. And we're talking now about all these otherwise healthy babies that will have enormous benefit from nirsevimab once the supply chain issue is worked out. So as a result, palivizumab is still really important for the high-risk babies that I just mentioned. It's cumbersome because it has to be given 5 times, because what Melissa mentioned earlier was that the nirsevimab is a long-acting monoclonal antibody. So it lasts for upwards of 6 months. And in contrast, palivizumab only lasts about a month, which is why babies have to get it on a monthly basis. It's also much, much more expensive. So in the long run, nirsevimab will replace palivizumab, but not this season. This season, we're still going to have to give palivizumab, and should be giving it, particularly because of the shortage issue.
Yeah. So still definitely a very important role in those very premature babies and babies who qualify. Otherwise, unfortunately, they do have to come into our offices every month. As you mentioned, Lisa, we are used to doing that. And we'll, of course, continue to give protection to these babies this season while we figure out the supply chain issues that are continuing to unfortunately happen. Before we transition, and we do want to talk about COVID-19, there are a couple of questions that are really interesting that came in the Q&A, and I think we have a couple of minutes to address them. What about the young babies who have RSV now? Should they still receive this immunization, this antibody? And if so, how soon after the illness can it be given? And I'll open it to you guys to answer that.
So we actually, Ashley and I are smiling because we actually just got asked this question from one of the pediatricians in our group. So even if a child did get RSV that season, we still want to give them nirsevimab, obviously if it's available, because as Lisa mentioned, there are different strains of RSV. And so it's important, we want to be protecting against the multiple strains. In terms of the timing, obviously we'd want a child to get over their initial illness. You actually can give nirsevimab, you know, if a child has a, not currently have RSV, but has another sort of mild illness, mild to moderate illness. Again, that's actually okay. It's really the sort of moderate to severe, similar to a vaccine, that we wouldn't give nirsevimab. The interval is interesting because I think there's, from a safety reason, there's no, it's fine. You can give it, you know, as soon as the baby's better. I'm actually interested in Lisa's response about whether immunologically, you know, does it make sense to wait a bit? The reason why I caution a little bit is that because of the supply chain question, right? You know, is it really worth trying to make that kind of calculation as to when the best time to give it would be if you have a child who has had RSV infection, is better now in your office, you have the product, you know, to try and hold it and have them come back. You don't necessarily know that you would have it in the future, but I'm very interested in hearing what Lisa, as the ID doctor, might say about it.
Yeah, and there haven't been formal recommendations by the Centers for Disease Control or the American Academy of Pediatrics. And I agree with you, Melissa. I think that also what we haven't really talked about, Edith, is it's a weight-based dosing. So this is a little in the weeds, but I'm going to do it anyway. So babies who weigh less than 5 kilos get a 50 milligram dose, which we have better supply of, much better supply of, and it's anticipated that throughout this season, that will be what we'll get. In contrast, babies who weigh 5 kilograms or more have to get a 100 milligram dose, and that one is going to be in very, very short supply. So if that little baby is growing well, they may miss their window also. So I think I wouldn't overthink it, but give it when we can. And one other thing that I just want to, I know the audience probably understands this, but it's worth mentioning. When we do clinical trials, we get all this amazing information that allows us to license a product and have it available. But then after that, we continue to study the nirsevimab or the maternal vaccine that we talked about. Ashley mentioned some of the more serious side effects that were noted that we are not sure if it was because of the vaccine or just coincidence. We're going to be looking at all of these things. And that's what's so important, that we continue to learn about the profiles, about the question that was just asked, what would be the optimal time to dose? We're going to learn that as things go on. So I think that's what's great about the modern era that we're in right now.
Yeah, no, it's so true. And I thank you for that reminder, because I do try to communicate as best I can to all of my patients that excitement about the way that we continue to monitor and continue to collect data even after a product has been extensively studied before it's released, right? So thank you for that reminder. One last question, and we will move on to talking about COVID-19. One of the reactions listed to receiving nirsevimab is rash. So the question is, where actually does the rash happen, and what does it look like?
It should be around where the injection was. So again, with this product, nirsevimab, it's all local site reaction. So there can be pain, redness, swelling at the injection site, but it shouldn't cause fever or other systemic symptoms because it's not, you're giving the antibody, you're not making the immune system respond to it. So it can look like any rash. There, is a small risk, as any product injected, of anaphylaxis. So if any of your patients have a severe allergic reaction to nirsevimab and are eligible for another dose in a second season, they shouldn't get it. But otherwise, it was well tolerated.
Yeah, I lied. One more really good one that came in.
Yeah, I think actually two really good ones. Just they're super quick answers. I just think, because I think we get these questions so commonly. I just want to make sure that we've answered them. I think the first is super quick. Can you give it at the same time as other vaccines? Absolutely. You give it. Don't wait to give it. It's not a problem. Give it in the thigh and spread it. Just like any time you give multiple vaccines, you want to separate them in that same thigh by a little bit. The second is, if there's a 100 milligram shortage, why can't we just give 2 doses of 50 milligrams, which, would make sense, except that the AAP has been very clear not to do that. It hasn't been studied that way. And also, insurance companies likely would not reimburse for both of those doses. So again, it would be not recommended, and there also is an issue around the reimbursement for that.
And I would just add also, Melissa, that we're still very interested in protecting those smallest babies. And so that's the reality of living with a supply chain issue, that we have to, really think about the most vulnerable babies and get the 50 milligram doses into them.
Yeah. And again, we're looking to a future where this is not an issue and we're not having to prioritize babies, even within the category of babies that qualify for this product, right? And someone else had asked the exact same question at the same time we were answering it. So I think it's really top of mind for people right now. So we can, you can continue to type your questions as we keep chatting. We are going to transition to talking about COVID-19, but definitely we'll save a little bit of time at the end if additional questions come in about RSV. So Lisa, I want to start again with you. I think many of us, when it comes to COVID-19, we've gotten a little bit comfortable with it. It's been with us for the past 3 years. And my question is, should we be feeling comfortable with it? And how much of a threat is it really to children right now?
Yeah, I know it's such we have gotten, I don't want to say complacent, but it became the new normal for us, right? And I think that my thoughts when I get calls from people, both as friends and family as well as patients, is we have to start thinking of it as like we think of influenza. It's with us. It's incredibly good at mutating. And in much the same way as we get an annual flu shot, what experts are saying is we're going to be getting an annual COVID shot. And I just want to say one very sobering thing, Edith, that really, even for me, I had one of those aha moments. Recently, the CDC and the American Academy of Pediatrics had a webinar about all of the respiratory viruses that we're talking about tonight. And they showed the vaccine preventable illnesses and deaths in children. And 600 children have died since June of 2022. And, we know that the COVID vaccine is very, very, very good. It protects people against severe illness. We'll tell people it doesn't necessarily protect people from getting infected, but if they get an infection, it's going to be mild. And we still are seeing children in our hospital with COVID. And we are still worrying about long COVID. Melissa is quite an expert in that. And we still have the concern about other side effects and long-term consequences of COVID. And given the safety profile of the vaccine, it just makes so much sense to get vaccinated for COVID just the way we get all of our other routine vaccines. So I would just say that we're so lucky, again, the modern era, that we're able to respond quickly, make vaccines that are protective against the variants that are circulating now, all of which are derived from the original grandmother of Omicron and just keep mutating. And the circulating variants now that we have in this area are covered by the current monovalent, it's called monovalent COVID vaccine. And we're not calling it a booster, which is also like a shift in our thinking, I think, which is, again, reminding us that it's a lot like flu now. Every year we get a flu shot. Every year we're going to get a COVID shot. That's what I think the crystal ball is showing.
Yeah. And I want to ask you, Melissa, a little bit more about the vaccines, but before we go there, Lisa, I wonder if you can talk a little bit about how much, and I think the reminder that you just gave us in that perspective of how many children, unfortunately, still die from COVID-19 and still land in our hospitals is such an important reminder. And I wonder if you can tell us just briefly how much COVID-19 is circulating right now in our communities, and what is the crystal ball showing about what's going to happen this season?
Yeah. So, there are, we're definitely seeing COVID. We're, like altogether, adults and children, since we are in New York City area, we have anywhere between 200 and 300 people in our system in the hospital with COVID or testing positive for COVID. And there are still deaths every single week from COVID in adults and much, much fewer in children. As we all know, children are remarkably spared, but not completely spared. Winter is bad time for respiratory viruses in terms of transmission. And there is a lot of modeling done, Edith, where based on what we know about transmission patterns, vulnerable populations, vaccines, et cetera, that really suggest that in our area, COVID will increase during the winter months, along with the other viruses that we're talking about now, RSV and influenza. So we are expecting, like every other winter, to have a winter with a lot of respiratory illnesses. So it gives us another opportunity to just talk about the basics of protecting ourselves and our loved ones from respiratory illnesses, which we're talking about vaccines. So we should just continue to emphasize that. But all of the other good things like lots of hand hygiene, not going to work sick, not covering your coughs and your sneezes. And it's like we'll get through it, but it will increase during the winter months.
Yeah. We've been through some tough winters recently. We have recent muscle memory, so to speak, but it's an important reminder of all of those best practices. So we really appreciate it. Melissa, let's talk vaccines. So what should we know about COVID-19 vaccines for children? What is the latest?
Sure. So as Lisa mentioned, we're really trying to have everyone think about it similar to a flu vaccine, right? So every year they're making sort of the flu vaccine that's going to best protect against what we know for that year. And it's the same thing for the COVID vaccine. So the current strain is protects against XBB, which is sort of a granddaughter of Omicron, as Lisa mentioned. And the current, even though right now what's circulating is a little bit different, RS or EG5, it still has very good protection against it. And there's another sort of variant kind of creeping up that might start to we might start to see. Maybe that's going to be the one that we see later in the winter. We're not really sure yet, and they think that has good protection against that as well. So that one is almost I would say maybe like a cousin of XBB rather than a sister or a brother. If we're going to use the family genealogy, it's actually or maybe a second cousin once removed. It's actually a step back up on the tree and kind of over. But they're all related to Omicron, which means that we would expect that the current vaccine to offer protection. For baby, for kids, if kids have already been vaccinated, then in previous season we want them to get one dose this year. We still want them to get it because again, we're trying to protect them against the current, the currently circulating strains. If kids have not been vaccinated yet, then they follow the primary series, and there was a question about that in there. So for Pfizer, it's going to be those 3-dose primary series with the boosters kind of in there. For Moderna, it's 2 doses. And again, it's going to be, there is actually no longer the old version that is completely off the market. It's going to be just this new version. If someone partially completed a previous series but didn't finish it, they'll just get kind of one they'll get a dose this year and they'll kind of be moving on. So again, it's really, I think, an important message that we really do want people to come in to stay, just like for flu vaccine, we want you to stay up to date with this season's variant. And I just want to very much echo what Lisa said. I actually do often talk to people about people who want to get very anxious to get their kid the flu vaccine, judging the flu, and we're trying to say it's a similar thing with COVID, right? There's actually more death, having more deaths from COVID than from flu, and we worry about flu a lot. So really need to be thinking about COVID, I think, in the same way, kind of same vaccination pattern and same kind of risk for our children, that we're trying to prevent those very serious outcomes, which we all obviously want to prevent in our own children and in the children that we care for.
Yeah. So absolutely taking it seriously, even though we feel like we know COVID-19, right? It is still such a serious illness in children. So I, really appreciate the reminders. Melissa, there were two questions that were somewhat related. So, for children who have already had COVID-19, first part of the question is, do you still give 3 doses when they first get vaccinated? And secondly, do you recommend waiting? The CDC recommends waiting 3 months after COVID-19 infection to give the vaccine. Is that the case for children as well? So still 3 doses, and do you wait?
Sure. So the first one first, yes, you still get vaccinated, and you still get the same number of vaccines. And actually, this kind of hybrid immunity is particularly effective. So if a child has just been infected and has never gotten vaccinated, their protection is nowhere near as good as if they were infected and had the vaccine as well. So again, that hybrid immunity, we want those children to have it. We still want them to get vaccinated. The CDC does talk about a recommended interval between infection and vaccination. Again, it's not that it's unsafe. It's really sort of to say, let's try and get the best boost of the immune system, especially again, if we're going to talk about this hybrid immunity. And the way I kind of think of it is let's sort of think about what's circulating right now. So, to me, if what's currently circulating is kind of what that child already had, then maybe waiting a little, it's okay to wait a month or two, but I wouldn't necessarily wait, more than the 3 months if I think coming in December might be, the next wave of it. And so you it's partly kind of doing that gauging, and partly also realizing we all know parents are incredibly busy. And so to say, I want you to come back, exactly on November 15th to get this next dose, you can cause more problems, right, when you're trying to be a little bit more precise about it. So I think, again, if a child has had it and you want to wait a month or two to start their to vaccinate them, that's fine, but I would not go wouldn't go too long. And definitely interested in Lisa as the ID doctor, in terms of her feelings about that, with December and a new strain likely coming, or a new peak likely coming again.
Yeah, you said it beautifully. I fully agree with what you said.
Great. So it's not like this hard cutoff, you have to wait 3 months. In this hybrid immunity, thank you, Melissa, also for that reminder that this hybrid immunity is a beautiful kind of immunity. It really is. So Ashley, to ask you a little bit about the vaccine schedule moving forward, I wonder if you can touch a little bit. So Melissa talked about those 3 doses for the primary series for the younger kids. I wonder if you can talk a little bit about what the series looks like to be fully immunized against COVID-19 for older children, and how it fits with other vaccines in the childhood immunization schedule.
Yeah, it's a good question. So the first thing that's important to know is that COVID vaccine can safely be given with other vaccines, because we know going into respiratory season, if you're due for COVID and flu and maybe a couple other vaccines, if you're a teenager, it is, a good number of vaccines that you're due for, but it's totally safe to give multiple vaccines at the same time. They just need to be separated by a small amount of space on the arm, or maybe even given on a different arm. And in general, the recommendations for people, especially if you've completed the primary series, is everybody 6 months and up is eligible for this updated COVID vaccine now, as long as it's been at least 2 months since your last dose. So for most kids who've gotten previous doses, they're eligible now to get a dose. And it really depends on the number of doses that they got before. So again, the youngest kids, if they never got vaccinated before, they're either due for 2 doses of Moderna or 3 doses of Pfizer. And then for the other kids, it just depends on how many doses they got in the past. But everybody, again, should be getting this updated vaccine. Everybody's eligible as long as it's been 2 months since your last COVID vaccine. And again, it's important to get now before, we do have these variants spreading in the community, but now that people are back in school and the holidays are coming, it's a good time now to kind of think about getting, protected, so that you're ready going into the holidays.
Yeah, you'd rather to gather safely and enjoy your holidays without an illness sort of setting you back. Ashley, I wonder if you could talk also a little bit about what the uptake has been for this updated COVID-19 vaccine, meaning how are parents receiving it and how many children are actually getting this updated vaccine?
Yeah, so that's a good question. So unfortunately, the uptake in especially the youngest kids is pretty low. So it's about, for New York State, it's about 10% of kids are fully vaccinated, or at least received the primary series for COVID. Obviously, many more kids have received at least one dose. So, at least one dose gives you some protection, but you really need to complete the series to get optimal protection. And again, I know that there are some, hesitations, especially because there's the belief that, COVID is like a cold or something like that. But as we've heard, COVID is and flu are both serious diseases that can lead to children being hospitalized and unfortunately have led to deaths in children. It's one of the leading cause of death in children, COVID is. So it's, really important to get those doses in and for patients who are behind to just recommend it. So, for the pediatricians that are on the call, it's really important to get the COVID vaccine in stock. The COVID vaccine is now commercialized, meaning you have to order it from a manufacturer. For those pediatricians out there who have VFC, which is where you get free vaccines from the government, you can easily order supply from them. But it's important to keep it in stock and to offer it to your patients. I know there's, vaccine fatigue and everybody says, oh, well, I'm already getting the flu vaccine. Do I need another vaccine? And the answer is, pediatricians are very well trusted by our patients. Like, of the doctors and nurses, like pediatricians are some of the most trusted doctors. And so even, recommending the COVID and flu vaccines for your patients, you can also recommend it to families. I often say to my patients, yes, it's important for, the child to get vaccinated, but also the whole family should get vaccinated, particularly if there's young children or elderly children or elderly people also living in the home, because the most vulnerable people are the youngest and the oldest. And so, yeah, especially now, we have good availability of COVID and flu vaccines. Everybody should go get them.
Yeah. And there was a time, we're doing it less now, that we were offering the parents the vaccine in our offices, just again, knowing how important everyone else around kids getting vaccinated against COVID-19 also is in protecting the entire family, and how important our role is in facilitating that actually happening, knowing that people just have very busy lives and a lot of competing priorities. So let's go to some of the questions coming in the Q&A. And again, please send us your questions. We are happy to answer them. And we have a very, very qualified panel to answer them this evening. So first question that I'll pose to you, to the group is, have there been any further studies or statistics regarding myocarditis in older boys after receiving the COVID-19 vaccines? Parents are still hesitant to vaccinate boys or to give that fourth or fifth dose. So I wonder if you could give us, whoever chooses to answer this question, give us a little bit of background and perspective on what we're referring to in terms of myocarditis and following vaccination and what that means, and if there's any updates.
Do you want me to start? With that one. So basically, yeah. So I think the first thing that's really important to understand is that COVID infection itself has a risk of myocarditis. So not vaccinating a child because of fear of myocarditis actually puts them at higher risk of myocarditis, because if they get a COVID infection, they can also get myocarditis. There was an original concern, which was definitely a concern for boys, particularly adolescent boys, with and it was thought at the time, actually looking into it more, was it probably had to do with giving the two doses so close together. So the original dosing, if you remember, for the Pfizer vaccine was, dose 1, 3 weeks, let another dose, or for the Moderna vaccine in the adolescents, to give them kind of closer. And now there is a recommendation to consider spacing it by, you could even space it by 8 weeks for that age group. And really doing that, we really had a very large drop in myocarditis after vaccination. I have myself 2 teenage boys. They're both getting vaccinated. One already was vaccinated. One just had COVID, so we're going to wait about an interval slightly just so that he has more protection. Later into the season. And I feel very comfortable with them getting now that I don't know what dose we're on, 5th dose, or we're again in that age group, because it's something that I know that the CDC has studied extensively.
Yeah. Really helpful for us as pediatricians to be able to use this information when we're counseling, right? That the initial rates of myocarditis that were observed, or inflammation around the muscle of the heart, were related perhaps to the dosing interval, and that the risk of contracting myocarditis after an actual COVID-19 infection is much higher. So really helpful as we are talking to our patients about this. The other question that came in the Q&A is, do you ever recommend Paxlovid for high-risk children when diagnosed with COVID-19? And specifically asking about patients with sickle cell disease, or and those patients that are at risk of severe acute chest syndrome.
So Paxlovid is licensed for 12 and up, but you have to be 88 pounds or more. And we absolutely prescribe it. It should be prescribed for the patients that were being described in the chat, for sure, assuming that they fulfill those criteria.
Yeah. Perfect. One additional question came in about RSV. If you have had RSV once as a child, will you get it again during your childhood? And then will you get it as an adult?
Yes. So the answer is yes. There's different strains of RSV, and you can get infected. And as we talked about earlier, you can even, as a young baby, get infected multiple times in the same season, because young babies, especially under 6 months, are at higher risk. And then later on in life, people are at risk of getting RSV as adults. So, in general, people that are healthy and young adults and middle-aged adults, they usually get RSV, and it's like a cold. But for both the youngest and the oldest, they have the risk of getting very ill and much more likely to be hospitalized and get very sick from RSV.
Yeah, perfect. So we have a few minutes left. I'm going to take this opportunity to thank our amazing panel of pediatricians, infectious disease specialists, who joined us this evening. Really, it is out of a passion to communicate this information and to keep our kids healthy. So I'm really, really grateful that you all have joined us. We have one additional question that came in, and I think we can squeeze it in. I wonder if you can give us an update on flu thus far this season.
It's coming, I think I would say, so similar to RSV, it comes from the south and up. So we're not quite seeing it yet, but we joke that you've sort of seen one flu season, you've seen one flu season. Flu can be a little tricky. We never know, it could come as early as November, it could be December. But what we do know is you want to get vaccinated before flu hits your community. And so that really does mean, the CDC really talks about by the end of October, and that's because it takes about 2 weeks to get immunity. So I would say the time is now, if you have not gotten flu vaccine, to go out and get it. And that will then give you protection when flu does start circulating. And then also for your own patients, really the time now is to get the flu vaccine. The other piece is some parents are still deciding. Again, just a plug for having those conversations. We like to think of a declination as a deferral. So I would say that for any of these, RSV antibody, flu vaccine, or COVID vaccine, if you have this with a family, they're still deciding, the next time you see them, please have that conversation again about any of these things that they're due for, because we do know that recommendation from their provider, their pediatrician, really carries so much weight. So if you're a parent, talk to your pediatrician or family practitioner. If you're a pediatrician or other clinician, please do have those conversations with your families.
And
Yeah.
I'll just add, we got a recent update from the Department of Health saying that flu vaccination rates are lower this year than they were last year. So it's really important to restart the conversation now, because again, this is a yearly thing. It's nothing new. And also just to make an announcement that flu vaccine is required for daycares, Head Starts, a lot of early child education. So it's better to just get it now, so parents don't have to come back later in the season to get flu vaccine, because again, it is required in New York City.
Yeah. Thank you for that question that we were able to squeeze in. So important to think about all of these things and talking to your provider, and for us as providers, talking to our families and patients, even if it takes multiple conversations. Again, so grateful to our panelists that joined us this evening. So grateful to everyone that also joined to hear the latest about this respiratory season, and what's available for families and in our clinics. We will be sending out an email with a recap, as well as this conversation will be available on YouTube for people to watch later. And we hope to see you next month. The topic will be announced very shortly. And thank you all so much for joining us. Have a good rest of your evening.